This is chapters 38 and 44, nursing care of the child with an alteration in intracranial regulation and or a neurologic disorder. So what's helpful to know here is that by the 4th week of gestation, the neural tube has closed. Your brain grows until your 5th year of life. And when we talk about the myelinated sheaths surrounding the nerves, that, if you remember, helps to conduct the impulses. So the peripheral nerves in an infant are not completely myelinated. So their coordination and fine motor skills are a little wonky, and it gets better with age. They have a subcortical level of functioning, which means their spinal cord reflexes, sucking, breathing, blinking, all of those things are subcortical, and they're able to do those things without thought. Their cortical functions, which are things that do require some thought, like memory and coordination, that's only a partial development when they're born, so we have to watch for their continued assessment and improvement in these areas. Their skull is not fused at birth. So remember when I said the brain continues growing until they're at least 5 years old? In a normal neonate, the skull is not fused, which allows for the growth. The anterior fontanelle closes at 16 to 18 months. That would be a good thing to know. That would be something you might be tested on. The posterior fontanelle closes by 2 months. We do assess head circumference on all infants on admission to the hospital. We sometimes will do serial head circumference if we have a suspicion about something occurring there. Because the cranial bones are not well fused at birth, they're at a higher risk for some fractures and issues there. The cranium is very soft in a preterm infant, and that allows for a lot of injury as well. The premature infant is at risk for more hemorrhage due to the fact that the area surrounding their lateral ventricles is super, super, super vascular. The sutures and fontanelles are present because that makes the skull more flexible, and sometimes you can even feel the suture lines, and you should be able to feel the suture lines on the top of the head in a neonate. These sutures and the fontanelles allow for that continued brain growth. Again, we're going to include past history, family history, history of present illness in our assessment, and our physical examination of any child that we're suspecting with a neurological injury or illness. We need to look at their level of consciousness very carefully, and we need to do an assessment of the cranial nerves. These are the 5 different states of consciousness. This ranges from a neonate to the geriatric population. We all have these 5 different states of full consciousness, confusion, obtunded, stupor, and coma. Look up the definitions. This is an old paper charting version of Glasgow Coma Scale. It's not a lot different from what you've done with adults already. It's a little bit different when you're looking at a neonate or an infant, but we're looking at eye opening, verbal response, motor response. In the charts in Cerner and in EPIC, which is used very frequently as well at hospitals, when you click on the eye opening, verbal response, or motor response boxes, they drop down and they give you your choices, and you go from there. A coma score or coma scale of 13 or higher means that you've had a relatively small brain injury. You're still functioning pretty good. 9 to 12 is moderate, and 8 or less is severe brain injury. And I believe that this is the same scale that we're using in adults and the same math. It's always helpful to brush up on your cranial nerves. It's impossible to remember all of this if you are not working in a neuro ward. We did have a neuro level at Loma Linda, and we treated all ages from infant to adult or adolescent and sometimes adults. Whenever I had to do a cranial nerve assessment, I would always refer back to some sort of a tool for a reminder. We had different little badge buddies or things on the computer that we could print out so that we could remind ourselves how to do the tests and how to assess for it. It's not something that you should have to memorize. I do want you guys to look at the table on page 1331. The table is listed as table number 38.1, and it goes over the pupils and the different pupillary responses you might see in neurological injury. I want you guys to use that table to fill in your notes, okay? So here is a table for early versus late signs of increased ICP. You really do need to know the difference between an early and a late sign. Because this is an extensive list of early signs, I've always found it easier to recognize and try to memorize the late signs. And if that's not listed in what's going on, then I know I'm okay. If you're looking to do something for a test, memorize your late signs, because those are the worst ones. You don't want to get there. If you're seeing it, it's bad. And just have a basic understanding of what the early signs are. And most of us have seen these early signs in adults as well, with concussion, tumor, different ventricular failure. So when you're thinking about it, it really is just all related to pressure. This is where we do want to look at the level of consciousness really carefully. And when you're dealing with infants and young children, you want to use the parents as your best resource. They need to be aware, and sometimes I even write it down for them, a little list of what the early signs and the late signs are, the things that we want to watch out for. And I tell them, if you see anything you think is strange, or you see these things on this list, you need to hit your call light. We need to come in, because it can occur really quickly, and we need to emergently get someone to manage this child. So the definition of epilepsy, which is seizure disorder, is a condition where seizures are triggered recurrently from within the brain. That means not from an external stimuli. And that's two or more unprovoked seizures occurring more than 24 hours apart. The prognosis is good for most children that do develop some sort of a seizure within their life, not necessarily epilepsy, but seizures occur in 4 to 10% of children, and less than a third of those are caused by epilepsy, febrile seizures, or neonatal seizures. And like I said, the prognosis is really good. Most children outgrow having seizures. That is not necessarily a diagnosis of epilepsy. So seizure is different from epilepsy, and make sure that you know the difference there. It is a disruption of the electrical communication in the neurons, and they're just firing all over the place when they're not supposed to. So nursing management, it's a focus on preventing injury during the seizure. We obviously can't do anything to prevent the seizure when it's already happening. So we're just trying to stop them from injuring themselves while it's occurring. This is a place where I want you guys to list on your notes what some seizure precautions are. So we do pad the side rails and we also do it in a crib. We pad the crib. We pad the wheelchairs. If they're going to be in a wheelchair and being pushed around the unit, we want to pad the sides. We also pad the sides of the little, sometimes it's like a little red wagon that they can be pulled around in. Anything that they're doing, even though we want them to feel normal, we still need to take those precautions. And when they're playing or just getting out and having some fun, we need to keep the precautions in place. We need to keep their bed and the area around their bed free from objects that could cause injury. Now, this is almost impossible with small children and toddlers because when they are hospitalized for any length of time, they surround themselves with 5 million objects, and you find crayons underneath them when you get them up out of bed, and you find, crumbs and crackers and pieces of things and sippy cups. There's always something somewhere. But what you have to do is when you go in and you see that they are seizing, start removing objects. So bedside table out of the way. Make sure that they're not holding anything in their hands. Remove things from around their head that could potentially impede their ability to breathe, like stuffed animals or big fluffy blankets. You're also going to make sure for every child you have come to the hospital that may be being investigated for some type of seizure or seizure disorder, you need to have suction and oxygen equipment that is available, but not just available, it needs to be set up and functioning. Frequently, you just room your patient and you're so caught up in doing an admission that you're not really checking your tools. You need to make sure that you have oxygen already set up and ready to flow with just a twist of the knob. You need to make sure that you have suction that is already set up. You've assessed the ability to suction. You leave it all there and hope you don't have to use it. So that's some of the precautions you need to take. During a seizure, there's good education that's available for you guys to look at on page 1348 in your texts. Also, the ATI children-focused sections on seizure is really helpful. So during a seizure, we want to protect them from injury. If they're on the floor, we want to try to put something under their head because they can hit it pretty hard. We need to maintain a position that is an appropriate airway. So try to make sure that you educate parents on how to maintain their airway and what positions would be the best for that. We turn them side-lying, usually at the end of a seizure, to make sure that they don't aspirate on any of the gunk that's collecting in their mouth. If they are wearing tight clothing, loosen it up, because they can injure themselves from buttons and things being too restrictive. Remind parents not to try to restrain their child. We don't hold down a seizure. It doesn't do anybody any good, and it could potentially cause injury. Also, it is an old wives' tale that we open the jaw and put anything in the airway during a seizure. We don't try to stop their tongue. They think they're going to swallow their tongue. If you position their head appropriately and you manage them with some oxygen, their airway should not be a problem. Putting things in their mouth can just damage their mouth. If they wear glasses, take the glasses off of them and set them aside. Get ready to put oxygen on them if needed, and you're going to stay with the kid. We want to educate families about the fact that, and what I like to tell them is, that child most of the time cannot feel anything that's occurring during this seizure. So although it looks very scary, they're usually not in any pain because their brain can't process that right now. So what we need families to do is to stay calm, note what time the seizure started, what was occurring around the time it started, and the characteristics of the seizure. And this means if one arm is moving in a certain direction, they need to note that. If the child's eyes are continually looking up and to the left throughout the seizure, we need to note that. The reason why that's important is because those types of observations give the neurologists some idea of where the injury in the brain has happened that is causing the seizures, and if that injury is spreading to other areas, which can happen. We also need to remind them that we just need to stay calm, and you guys need to stay calm. We are going to encourage normal activity as much as possible. Children who have seizure disorders shouldn't be managed or shouldn't be treated any differently. But we need to teach them how to develop their positive self-image and remind parents to work on their self-esteem with them, because they will feel different. Medical management of these kids, we're going to focus on controlling the seizures or reducing their frequency. Sometimes we can't always control them, but at least we can make it less frequent. We're going to teach the family and the child how to live with a seizure disorder. One of the main ways that we treat seizure disorders is anticonvulsants, and there's a table on page 1396 of your texts that have some common anticonvulsants. One of the things that we like to focus on is trying to give them the fewest amount of drugs with the fewest possible side effects. We don't want to load them up when they're that young with tons and tons and tons of different medications. It does take time, and we do have to relay that to parents. It takes time to find the right combination that's going to control them, and sometimes it takes time to find the medication that doesn't cause them very many side effects, or the right dose of that medication. So it's not a quick fix, and they have to be patient and understand that it's going to be a process. There are times where we can do surgical management to remove or treat the area that the seizure activity is occurring in. So some other treatments that might be used are things like a ketogenic diet, and we can discuss that in class, and placement of a vagal nerve stimulator. Those have been pretty helpful for some patients. I do want to say really quickly, there's not a ton of evidence that a ketogenic diet is helpful in any way. It's still considered kind of an alternative treatment. There's not a lot of proof. There's just anecdotes about it working. If you ask me about a patient with a ketogenic diet in class, we'll have a discussion about a really sad case. Types of seizures. There's a lot. Focal seizures and generalized seizures are two different things. So a focal seizure, if you think about it like being a pinpoint, I think of the focal seizure being one tiny pinpoint area in the brain that is affected, and this causes a very specific type of seizure. It's going to be different in every single person, but a focal seizure can be something as simple as just kind of turning your head in the same direction frequently, almost like a tick, it looks like. They can have impaired consciousness or no impairment of consciousness. There are some focal seizures that manifest in different areas of the body. Like I said, the head, you might see just one arm moving. And it's really strange to see this happening when it's a child who is not unconscious. And it takes a second to try to figure out if this is a normal activity for them. So this is where you bring the family in. Does your child do this on a regular basis? No? Okay, then we're watching for this now. Sometimes they just have like a tingling or numbness that occurs in an area of the body. And there's other times where their behavior is really altered. And maybe they can't respond to you when you're asking them questions, but they look awake and alert. They might be very confused or unable to remember things during the seizure. So it really looks like they are a functioning, normal, awake child, but something is occurring that is not correct. So it's hard to decipher with focal seizures. It's very, very good to have a good description from the family of what they saw that caused them to bring the child in, because we're going to continue watching for that. Generalized seizures, there are a couple different types. There are absence, tonic-clonic, myoclonic, and atonic. An absent seizure is also called petit mal, which means it's a bad little thing. Usually these are like a loss of consciousness where it's like real quick, 5 to 10 seconds. They just kind of sit and stare. Often kids in school, their teachers or their peers think that they are just daydreaming, but it's actually seizure activity. There might be absolutely no change in their behavior. They might drop something that they're holding. So they might have a pencil, a pen, a cell phone, whatever in their hand, and it just drops onto the floor and they don't really respond to the noise. Sometimes with an absence seizure, they might have certain movements like twitching in their eyelid, or a side of their face twitches and twitches and twitches, or they smack their lips over and over, or almost like a pill rolling movement of their hand. We call that an automatism. Strange. They usually can go right back after the 5 to 10 seconds of a absent seizure to doing whatever activity they were doing. So on the flip side, a tonic-clonic seizure, this is what most of us associate with seizures. It's called a grand mal. These occur without any warning. It's the most common type, so this is a good one to know the things about. In the tonic phase, it can last up to 10 to 20 seconds. There is a loss of consciousness. It's a contraction. So tonicity is your muscles contracting. So they become very stiff. They extend their whole body. Their arms are flexed, their legs are flexed, their head and neck can be stretched out. It's hard to open their mouths. They become very hard to oxygenate during a tonic phase. The clonic phase can be up to 30 to 50 seconds, and this can last up to 30 minutes. So they can be long if they're untreated. This is where you see the jerking, the foaming in the mouth. They might lose urine or bowel control, and these movements, from the contraction of the muscles in the tonicity to the jerking and the clonicity, these movements are all going to kind of slow down over time until they just go away. And then they are in a post-ictal state that can last up to a half an hour. Post-ictal, they are conscious-ish, but it's hard to arouse them. They stay confused usually for a while, and they have a lack of coordination. They might vomit. Again, why it's important to have them side-lying when they're in their post-ictal phase. They might sleep for a really long time, and they're going to be tired and sore because, my goodness, their muscles just went on a, marathon. They do not have any recollection of the seizure. So this is where you explain to the parents that they don't feel it, they don't know what's going on. Just control the situation as best you can. A myoclonic seizure is usually it's really brief contractions of muscle or muscle groups. So it might just be one or two extremities. It might be just their face. They might not lose consciousness. So this is very similar to a focal type seizure, right? There is no post-ictal state in myoclonic seizure, just like there is no post-ictal state really in a focal seizure either. So we do want to make sure that we give as much information as we can to the neurologist. We are never going to be the ones who say, oh, this is definitely a focal seizure, or oh, this is definitely a myoclonic seizure. They are going to say that, and we're going to treat accordingly. An atonic seizure is known as a drop attack. Usually this is like they're 2 to 5 years of age, and all of a sudden their muscle tone overall just goes bloop and it's gone, which causes them to fall, and then they're confused. These kids, most kids with seizure disorders that have been repetitive, they do need to wear some sort of helmet when they're out and about. There's also all types of unknown or unclassified seizure disorders, and I don't need you to be aware of any of those. You just need to know that when a kid comes in with a seizure disorder or they're having seizures in an outpatient setting, you need to do the exact same amount and type of education to the family, and you need to do the same preparation pre-seizure and the same management post-seizure for all of these kids. Febrile seizures, this is a good one to know because this is a common thing. It's associated with a sudden spike in temperature that can go up as high as 104 or more. The seizure usually lasts 15 to 20 seconds. The best thing to do to treat these kids is to give them Tylenol or ibuprofen if it's age appropriate whenever they have a fever, and give them like cooling measures with lukewarm baths and putting cool washcloths in the groin and the armpit and the back of the neck, and dressing them in light loose clothing when they're out and about so they don't overheat. Okay, status epilepticus is prolonged or clustered seizures. Consciousness doesn't come back between, there's not enough time. When we treat these, we are trying to get them out of status. It's not always possible. We're going to do basic life support, and we're going to give them anticonvulsants the best we can. It's hard if these patients come in status and they don't have a line already, because they are usually having a pretty severe tonic-clonic type seizure, and it's very hard to get lines in them. We do use a lot of nasal and rectal administered drugs. We give them as much diazepam, benzos as we can, lorazepam and diazepam. This slows everything down. We can also use an old school anticonvulsant, which is called fosphenytoin. It has a pretty fast onset compared to other anticonvulsants, which is 15 to 45 minutes. So we will load them with that as well. And again, we're going to try to keep the area that they're in as safe as possible for them. We're going to put oxygen on a patient who's in status. We're not going to wait and see how they do. They're not doing well. So we're going to put oxygen on them, probably 6 liters, fully open, face mask. And we are going to make sure that suction is like stick it behind the pillow and be ready to use it. It needs to be ready to go. These are 3 disorders we're going to talk about: hydrocephalus, spina bifida, meningocele, myelomeningocele, which are all structural disorders, and we're going to talk about Duchenne's muscular dystrophy. Hydrocephalus, you'll find information about this on page 1352 of your texts. It is a collection of fluid. It can result from an underlying brain disorder or from blockage or obstruction. So this is what they used to call water on the brain. There's 2 types. There's obstructive or non-obstructive. That's pretty self-explanatory. The medical management for children with hydrocephalus is that we need to identify them really early, because they're at a really high risk for developing developmental issues if it's not managed appropriately early. So one of the ways, and I want you guys to go into your text and look at the different ways that you can identify that they are possibly having or presenting with hydrocephalus. So early identification, list what it is. VP shunts, these are placed in the ventriculoperitoneal space. They put it into the ventricles and of the brain, and it shunts the fluid down into the peritoneal cavity of the abdomen so that it's displacing this fluid. VP shunts, they malfunction often. They need to be replaced as the kid gets older and they grow, because they're going to have more fluid to manage. We need to educate the parents on the signs and symptoms of malfunctioning. So you need to know what those signs and symptoms are. Often it's the same things that you would attribute to increased intracranial pressure: vomiting, headache, irritability. Severe lethargy is a late sign. So look back at the early and late signs of increased ICP. These are very similar to the signs and symptoms of a malfunctioning VP shunt. Some of the complications of a VP shunt are infection, obstruction, and a need for revision because something has failed within the device itself. So if the kid has had a shunt in place for, let's say, I don't know, 2 or 3 years, and it hasn't been replaced, the likelihood of an infection occurring in there is not high. Infection we're going to see usually within the first 1 to 2 months after we place it. We treat shunt infections with IV antibiotics, and if the infection can't be treated easily and it persists, they will replace the shunt. Depending on what type of shunt they have, um, it's a relatively short surgery. My foster son had a shunt placed, but it was an external shunt. I'll explain that to you. Normally you can't see them or feel them. His, you could feel it going from behind his ear and then down his neck and over his clavicle. Um, Part of the nursing management of children with shunts is that we want to recognize the cues of shunt infection and malfunction. Um, you want to provide support to the family. They're going to be repeat customers at the hospital often, and they're going to be tired and they're going to be stressed out. So we need to give them as much support as we can, and we need to get them in touch with as many resources as we can. So we really want to be best friends with our case managers and our social workers, so that they can attach this family to resources out in the community that they desperately will need. Spina bifida occulta is usually what we're speaking about when you hear the term spina bifida. This mostly affects the lumbosacral area. We don't see it from the outside. The things that we might be able to see are the little tufts of hair that we talked about right above um, the sacral area. So where you would see those little dimples. If the dimples are pretty pronounced, that can be an indicator of spina bifida occulta. They have the little dark hair tufts. They might have what's called a subcutaneous lipoma, which is like a little fatty tumor that is benign underneath the skin in that area. And then some of these children might be born with what's called a port wine angioma, and that's the red birthmarks. They can do diagnostic procedures here, ultrasound during pregnancy to show if there's an actual visual defect, but they might not be able to see spina bifida occulta. So one of the issues with this is that the spinal column, the osseous structures are not fused correctly, and it allows a little space, which means if you have space down towards your sacral area of your spine, the coccygeal region, that's where a lot of elimination is innervated. So the nerves that function to make us urinate or have bowel movements, those are in that region. And if there's too much space between the actual osseous portions of the spine, then the nerves are just kind of dangling there and hanging. They're not touching the structures that they actually need to touch to innervate them for those activities to happen. Some of the risk factors for the development of spina bifida occulta are medications that could be taken during pregnancy, if the mother was malnourished in some way, if they didn't have folic acid during their pregnancy. And remember, the neural tube is supposed to close at how many weeks of pregnancy? So really our folic acid ingestion needs to be before we ever decide we want to start building a family. Duchenne muscular dystrophy. This is an inherited disease that is a disease that causes muscular wasting. The life expectancy has increased. It used to be if you had this, you died probably before you even made it out of junior high. We've gotten up to the 40s and 50s now because we're able to support these patients' respiratory status with mechanical ventilation, even in an outpatient setting. And we use ACE inhibitors to manage their cardiac dysfunction, because if it's a muscle wasting disease, it affects all the muscles, including the smooth muscles, cardiac muscles. This is, again, mostly males. So some of the symptoms or cues that you might see in a child that might lead you to wonder if they have Duchenne's muscular dystrophy are that they stumble and fall a lot, their balance is really poor, and they might have large sized calves in comparison to the rest of their body. Sometimes if they try to climb stairs, they're really, really clumsy at that. And if they fall down on the floor, they have a really hard time getting up from it. These kids usually walk on the balls of their feet. They kind of look like they're waddling. And Gowers' sign is literally the inability of the kid to get up off the floor if they fall, because of the weakness that's becoming progressively worse. Sometimes by the time they're junior high age, they've lost all ability to walk. They might not be able to raise their arms or legs at all. And they might need truncal support just to be able to sit up. There is no cure for Duchenne's muscular dystrophy. We might treat them with the steroids, calcium supplements, antidepressants, use braces and orthotics, positioning aids. They might have spinal surgery if they're still able to walk, to help with their mobility. And we're going to do PT and OT with weight-bearing exercises. We're going to stretch them. And we're going to try to strengthen their muscles, but this is progressive. Sorry, you're going to hear my dog barking like a rooster crows often. Bacterial meningitis, what is it? It's an infection of the meninges caused by a bacteria. This is the meninges, I hope you know, surround your brain and spinal column, so this is dangerous. Risk factors for bacterial meningitis. We see different infectious agents like meningococcal types, streptococcal types, pneumococcal types. We also in the Central Valley see a lot of cocci meningitis because of valley fever. They can also develop bacterial meningitis from trauma to the head. So anything that's able to penetrate could put a bacterium in there. Crowded living conditions are also another risk factor. Some of the cues you might see in infants, it's not going to be real easy to see it. The signs are like poor sucking and feeding. They cry really weak. They're lethargic. They vomit. Those are in the early times. When it's a late sign, you're going to have a really high-pitched shrieking cry because of the pain. Their fontanelles are going to bulge a lot, and they are going to become Brady. So those are late signs. You need to know those. Children will exhibit positive Kernig and Brudzinski signs. There's pictures in your book, and I will try to find some videos of Koenig and Brzezinski to put on the board. At the point that you see all of a sudden a purpuric or petechial purpley rash develop, that's a bad thing. It's indicative of meningococcemia, which is an immediate medical emergency. Sorry you guys have to hear me clearing my throat so much. The smoke and the air quality is really affecting me. So some complications from bacterial meningitis, obviously we can lead to brain damage, nerve damage, deafness, stroke, and then to death. I want you guys to find out and figure out how long they need to be in isolation and what type of isolation. Part of our nursing management is to isolate them, place them on antibiotics, and do strict I's and O's. We usually don't start the antibiotic until after we're able to perform a successful lumbar puncture. Some of you took care of an infant in the hospital setting that they failed the lumbar puncture. And they didn't try again. They found it to be more important to place that child on antibiotics quickly. So we do lumbar puncture, blood cultures, then we start antibiotics. We do accurate I's and O's, and we assess that child's fluid status because we don't want to overhydrate or dehydrate them. We also do neurovascular checks. We're going to educate the family on prevention and immunizations. This is part of the reason why immunizing is important. We're going to look at, when we do the lumbar puncture, you're going to be able to tell whether or not it's bacterial versus viral based on whether or not the WBCs are high or low, the protein is high or low, and the glucose is high or low. So I like to tell people that in a bacterial infection, the glucose is low because the bacteria is chomping it up. It's eating it. It's using it. And then the protein tends to be high because they're pooping that out, and that increases the protein. There could be other reasons why, but that's how I remember it. We also give these children steroids. Why? Because we're decreasing inflammation. Part of the management of children with meningitis or neuro involvement from a number of different illnesses or syndromes is that we want to decrease their environmental stimuli. So we turn the lights down. We don't have 5 million electronic devices on. Keep the TV off. Play some soft music or none at all. That child doesn't need to be staring at a cell phone all day. They're going to increase their headaches. Their eyes are going to start really hurting. They're going to become more and more irritable just simply from the environmental stimuli. And we like to let parents know to decrease the amount of visitors. Most of the time they're going to be in isolation anyways, but visitors still want to come and they'll gown up and mask up to get in there. They need to lay off. Also, we implement seizure precautions for bacterial meningitis. Keep the bed low, lowest position, want safety, and we're going to raise the head of the bed and use pillows to prop them. So aseptic meningitis, we usually call this just viral meningitis. It's the most common type. It's usually kids under the age of 1, and it's caused by a virus in the meninges. The signs and symptoms are similar to bacterial meningitis, and you're going to look for the same late signs of the bulging fontanelles, the high-pitched shrieking cry. We are going to do a lumbar puncture and blood culture and CBC, and we're going to treat them aggressively with the antibiotics. Then when we see negative bacterial involvement in the lumbar puncture, then we might start them on antivirals. We're usually just going to have them on comfort measures like giving them some fluids and Tylenol and or ibuprofen depending on their age, and try to support them with pain and just getting back to kind of normal with eating and drinking and sleeping. This typically is a 3 to 10 day length of time, and then we're done. Ray's syndrome is a syndrome that is caused by a child who has had a viral illness, usually like the flu, a gastroenteritis, or like chickenpox, and the family treated them with an aspirin salicylate containing product. This leads to brain swelling, liver failure, and likely death if it's not treated. Some of the signs and symptoms or cues that you're going to see are lethargy, severe irritability and combativeness. They're going to be super confused and often delirious. There is going to be profuse vomiting, seizures, and loss of consciousness. We do a quick LP on these kids to rule out bacterial meningitis. We might start them on a medication like mannitol. You should look up what that is. I want you guys to be able to tell me 3 products that might be used by unknowing parents to treat their child during a viral illness. 3 products that might be used that have aspirin in them. Because Ray's syndrome affects the liver, these children become what we call hypercoagulable. So we want to monitor their coagulation status, and we want to prevent hemorrhaging. We're going to apply a lot of pressure if we do any procedure that could lead to bleeding afterwards, like the lumbar puncture. We're going to have intubation products at the bedside, and we're going to keep the family informed of what's going on, and try to provide them with as much education as we can. Some of the things that we monitor are their LFTs, their serum ammonia levels. These being elevated is part of the reason why, aside from the increased cranial pressure, that they are becoming delirious, confused, having projectile vomiting, and being very combative. We're also going to monitor their fluid volume status, and we're going to try to maintain their comfort. Cerebral palsy. This says it's a range of non-specific clinical symptoms characterized by abnormal motor pattern and postures caused by non-progressive abnormal brain function. Basically, you have a hypoxic injury, usually in and surrounding the time of birth. And that hypoxic brain injury leads to these abnormal brain functions. It can be very severe. It can be not so severe. You might work with a person who has cerebral palsy. They might have just maybe a little bit of a limp and an arm that doesn't work as well. You might meet someone else who has cerebral palsy who just has some speech issues, but the rest of their body works just fine. Or you can work with a patient who is bedridden, unable to move, has some contractions, unable to talk or communicate in any way. The problem with this is that most of the time cerebral palsy really doesn't affect the higher brain functioning. They're able to understand and learn and think the same as anybody else, and sometimes their bodies are just trapping them in that state. So the signs and symptoms or cues, this is really going to vary depending on where or what part of the brain was involved in the hypoxemic event. Sometimes it's not just hypoxia, sometimes there is an actual trauma to the brain that can cause this, but it's usually always related to a hypoxic issue. So for diagnostic workups, we're going to do a complete neurological assessment. We are going to do some metabolic and genetic testing to rule out other disorders. We're going to assess the way that the child is able to move. we're going to do an MRI to evaluate the brain and any other abnormal areas. So, and also an EEG, x-rays of the skull can be done, and ultrasounds. Your role in this is to help the family manage the child during these procedures and or provide sedation and recovery from the sedation for these procedures. It's really hard to do an MRI on anyone school age and younger. They don't like to lay still. So we do usually sedate them. We like to use ketamine for that. Some of the nursing actions for children with cerebral palsy, we're going to promote their mobility as best we can using orthotics and positioning aids. We're going to promote their nutritional status by making sure that they have adequate protein intake. We're going to give the family as much support and education. So we use something that's called a baclofen pump frequently in these children. If they are functional and able to get out in the world, walk around, we use the baclofen pump to decrease the tonicity or spasticity of the muscles. If we can override their brain's need to make that muscle kind of spastic and constantly in a state of flexion, then it makes things like walking and breathing and talking easier. A baclofen pump just constantly gives them a little bit of it all the time, and it decreases their tone. Most CP patients take oral baclofen. It's very lucky ones that get to have the baclofen pump. We do treat with botulinum toxin because it can help with, if they are a active CP patient, they might still have some drooling. So we'll give botulinum toxin to try to decrease the drooling so that, you know, they can function in the world without being embarrassed of that. And then we do treat athetoid type cerebral palsy, which I'm not going to test you on, with anticholinergics.